Excellent. All right, so welcome again, everyone, to this session 3D, and we'll begin with Tiffany Kuku and her poster.
Okay. Okay, can everyone see my screen?
Yep, perfect.
Okay, perfect. Hello, everyone. My name is Tiffany, and I will be presenting my work exploring reasons for use and relative importances regarding hormonal contraception. This research was conducted as part of a bigger project using Stephanie Tandy's honors thesis and data with the supervision of Dr. Duchenne at the university, the Department of Psychology. Since its conception in the 1950s, scientific and technological advancements have resulted in various types of hormonal contraception with different compositions as well as modes of administration. So HC has a diverse reasons for use, ranging from medical to contraceptive use and non-medical uses. However, we know little about this in the Canadian population. So we aim to provide preliminary descriptive data on the reasons for use, their relative importances, sources of information used by the participants, as well as the general knowledge that they have about HCs. To do this, we utilized a survey which was called the Context of Hormonal Contraceptive Medications Assessment, which was adapted for the UNBC student population. We had a total of 71 participants, but based on data quality, we only retained 68 of those responses for final analysis. Some of the findings there suggest that there is a variability in user motivations and reasons for use that influence participants' anticipated as well as experienced effects. When analyzing reasons across the three usage groups, which are past users, current users, as well as past and current users, we found significant variations in motivations. The reasons for use across all participants was primarily menstrual-related reasons, and it ranged from menstrual pain, regulation of cycle, or the reducing of periods entirely. While contraception was also frequently reported, it often appeared more frequently as a secondary motivation. Other notable reasons that we saw were mental health related reasons, health reasons, as well as skin regulation, which suggests that there is still a variety of motivations for use. In terms of knowledge, participants had an average knowledge about the use of HCs and the general beliefs about hormonal contraceptives. However, there is need for improvement when it came to long-acting contraceptives, so IUDs, for example. In conclusion, our descriptive data contributes to the literature by reaffirming the complexity of users' motivations and the reasons for use, as well as the relative importance that they place on these reasons. So, for future steps, we do want to relaunch the survey in the university, as well as expand efforts to the north and outside of the university to gather additional data to support these findings. Thank you.
Thank you very much, Tiffany, and you're on time. Okay, all the best for the next steps in your project. Seems like it's quite novel and its application in the Canadian context. So well received. Thank you. And there is invitation to continue interacting with each other through Feedloop in the rest of the conference. Okay. Now I believe we're gonna have a team of Robin, Rai, and Krista. Am I correct? Perfect.
Yeah, that's right. Myself and Krista will be presenting this one. Robin is part of the team, but we're just Krista and I will present.
Excellent.
All right. Is everyone able to see that?
Yep.
Perfect. Okay, so hi everybody. Welcome to our poster presentation on sustaining rural practice, a proposal to address educational needs of sole charge, physiotherapists, and occupational therapists. Our team consists of myself, a physiotherapist who recently took on the role of the physiotherapy educator for Northern Health, Krista Sipprell, an occupational therapist who recently took on the role of occupational therapy educator for Northern Health, and Robin Roots, who's the clinical lead for the Master of Physical Therapy North program at UNBC, and a researcher whose work has investigated rehabilitation professionals working in rural and remote locations.
The idea for this project began when Ray and I started in our roles as educators. We connected with clinicians in remote communities in sole charge positions. We heard about the challenges that they faced and the lack of recognition they received for their uniquely difficult role. We heard from experienced clinicians about their frustrations that specialist PTs and OTs receive higher pay and perceived status, and these clinicians felt their roles should be considered a specialty in its own right, a rural generalist specialty. We also heard from new grad PTs and OTs who had entered into sole charge rural practice, only to find that the lack of professional support and difficulty of the position was overwhelming. And unfortunately, many of these clinicians have since left their roles.
What we heard anecdotally from these clinicians lines up with what is found in the literature. To support retention of these clinicians, they need professional support and access to professional development, recognition, and a clear understanding of what their role will entail. Krista and I felt that in our new roles, we needed to do what we could to support these clinicians in the hopes of supporting retention in rural and remote locations.
The initial impulse was to dive into designing and creating a curriculum that could support these clinicians. After all, that's what educators do, right? Fortunately, Robin was there to slow us down and get us asking the right questions. Why did we think a curriculum would help? How would we decide what to include? Ultimately, we laid out the roadmap you see in front of you. We're at the very beginning performing our literature review. We have a plan laid out, and this will likely change as we gather more information.
We are excited to explore this topic, the existing research, and the survey and focus group results when they come. Mostly, though, we are hopeful that this research will lead to better support for sole charge clinicians in rural locations throughout Northern Health.
All right. Excellent. All right. Thank you very much for this and all the best. I'm sure there's going to be interesting steps coming up, but this is a quite unique topic and also connected to education and retention of our workforce. So congratulations, Krista, Ryan, and team for embarking on this journey. You are more than welcome to be back in 2027 with all those results, right?
Yeah, exactly.
Great. Okay. Next in line is Joanne. Joanne Vigue. Excellent.
Hi there. My name is Joanne Vigue. I'm a surgical clinical reviewer here at UHNBC, and I work for the NSQIP program, which is a National Surgical Quality Improvement Program. So we did a project, which is actually over here at the end of May, decreasing surgical site infections for elective total knee arthroplasty and total hip arthroplasty here at UHNBC. I was lucky enough to work with two great physician leads, Dr. Paul Van Ziel and Dr. Tyson Betcher, who are both very busy today, as well as Cynthia Hiller, who was NSQIP, Jocelyn Raymond, our PQI coach, Arindu Lineage, as well PQI, and all of perioperative services. So, sorry, just a sec here. Basically, NSQIP data was showing that we had an increase in our total knees and total hip surgical site infections. And after some deep dives into these infections that we were seeing, as well as some good discussion around possible interventions, we came up with the problem statement and Project AIM, and we actually came up with this poster which was put up in the operating rooms to involve the staff in the plan. So basically, what we were trying to do was decrease the surgical site infections in total hips by less than 2.5% and total knees to less than 2% by May of 2025. So the next thing we did is we came up with some interventions. So preoperatively using some chlorhexidine wipes on patients, removing hair outside the operating room, nasal colonization, intraoperatively antibiotic sutures, Postoperatively, we did an extended duration dressing as well as education for emerge physicians and primary care providers. So the education component was actually a really big part of our project, as we all felt there was a lot of cases, particularly total knees, where antibiotics were getting prescribed without consultation from surgeons. So Dr. Benziel and Dr. Betcher both presented to their colleagues in the ER as well as primary care providers on this matter, and it made a really significant impact on our SSI diagnosis and as well as consultation to orthopedic surgeons. So here's our results. So as you can see here, we started at for total hips at 4.24% and dropped to 1.91%, well below our target. So we're very proud of that. Our PQI analyst, Randi, was so helpful and gave us these beautiful graphs every month to post in the operating room so that they could share in the success. For total knees, doing well, but not quite as well, 4.14 to 2.76. Again, a lot of this focused around the education on these joints truly infected. So last slide. Plans moving forward are to uphold these best practice standards that we implemented here for our orthopedic surgical care team through both surgeon leadership and our NISCRIP data analysts, and also going to determine interest and support such a red package to other Northern Health sites. And lastly, use some of these interventions that we used for this project and some other perioperative services. And that's it. Thank you very much.
Thanks, Joanne and team. This is a great team effort, including beautiful graphics, as you referred to, and a great collaboration. All the best for this project and next steps.
Thank you.
All right, next in line is Randi, Leanne, Parsons. I can see you.
Excellent. I'm just getting the screen share going. Just shout out when you see that there. Can you see it, Marcelo?
No yet. It says you have started, but it's not showing. Still black.
It looks like it's loading. I hope it's going.
That's fine. Yeah.
It says you're screen sharing, so
Yeah, it is now. Yeah,
happening.
it is now on.
Okay,
Good to go.
excellent. Perfect. Thank you, Marcelo and team. Good afternoon, everyone. It's an honor to be in circle with you all today at this conference. My name is Randi Leanne Parsons, and I gratefully hold the role of Regional Nursing Lead for Maternal Infant Health with our Northern Health Public Health Practice team. I'm here today to share a special area of work in my portfolio that focuses on prevention of traumatic injury due to child maltreatment, which is called THI-CM. I need to offer content warning as this presentation does discuss child abuse towards infants and young children. I acknowledge this topic may be triggering and difficult for our audience. Please take care of yourself as you listen. One of public health's greatest strengths is our ability and our passion to prevent illness and injury and to promote the health and well-being of our populations we serve. We champion health equity and advocate for a responsive health system, especially for families where social determinants of health are causing barriers and health inequities. And at its core, that's what we're doing with this work. Inconsolable crying is the #1 trigger for infant shaking and other forms of abuse for children under the age of 2 years. To protect all children and families in British Columbia, Northern Health, alongside other BC health authorities and BC Children's Prevent Shaken Baby Syndrome BC program, has partnered since 2009 to implement the Pure to Purple Crying program. Please scan the QR code at the bottom right of the screen to learn more. And over the last 2 years, our team has refocused efforts to strengthen regional awareness about purple and the importance of THI-CM prevention. So I'll take a moment in this presentation to highlight some of that work. The first prong has been a public and staff education campaign. I want to first by acknowledging the Northern Health clinical teams, both in acute and community. Between April 2024 and March 2025, over 700 participants in Northern Health completed the BC chronic purple crying implementation training, which included 128 nursing students. This really demonstrates our commitment in the North to prioritizing this important area of work. Next, I want to highlight a successful education program that we offered to our acute and community staff earlier this year, where we had a wildly successful engagement with our colleagues. 117 folks participated, and over 80% indicated the work was useful for their work. Next, I want to highlight the chart reviews that we're undertaking. This work, we're seeking to understand which risks and factors may be associated with violence and families and more. We're advocating for enhanced support for families living with complexity, and we're seeking to engage in more focused conversation with local leadership, both in acute and community, to prioritize and strengthen THI-CM prevention. Right now, data analysis for the chart reviews, looking at emerging themes, is in progress. And lastly, we are undergoing a renewed public awareness campaign. You may be seeing different images on Northern Health social media around this right now. Last year, we distributed over 1,300 knitted caps to babies in the North, and we're continuing this work this fall and winter, engaging with Northern Health volunteer services as well as the hospital auxiliaries, and continuing this campaign annually moving forward. And next steps, our work continues with conversations like this today, presenting the importance of THI-CM prevention with you all and other audiences. We're building in regular work where the Purple campaign continues, as well as strengthening our relationship and the importance of this work in both acute and community settings. And as I close, I want to take this opportunity to thank my team. I'm so proud of all the colleagues I work with, and there's been so many, I can't name you all, but from my heart to yours, thank you for your support in this work. And thank you, Marcelo and team, for having me today.
Thank you, Randi, for this beautiful project, and also your passion about working on this, and also the involvement with different important actors with the community. So all the best for this project, and yeah, great learnings. Next in line we have, unless there's questions, but I don't see questions. Otherwise, maybe we can sort of prepare some questions for the end. Next in line we have Shendah, Benoit, and Kara Hagblom.
Right. Okay. Sorry, the space is about to be filled with children, so I'm going to have to move as quick as I can. Okay.
Not a problem.
Let's see here. Sorry, guys. I'm just looking for my slideshows.
Early dismissal has started. I repeat, early dismissal has started. Thank you.
Okay. Sorry. This is like, oh, there we go. Slideshow from beginning. There we go. Okay. Good afternoon, everyone. So we're so pleased to be joining you today to present our research on exploring strength-based strategies with rural parents of children with autism. My name is Kara Hagblom, so I'm a recent graduate from UNBC, having earned my Master's of Education with a special focus on strength-based learning and advocacy strategies for neurodiverse children, including and especially children with autism. I'm also an educator with School District 57, and I've worked as a resource teacher for almost 11 years, supporting and case managing students with a wide range of exceptional needs. I currently teach full-time in a small rural school just north of town. I'm also the proud parent of 2 teenage children, and my eldest son also has a diagnosis of autism. And then I will briefly turn it over to Dr. Benoit.
And so I'm joining from the School of Education, and I guess I lean largely into our Master's of Education in Inclusive Education. And I'll just speak to the theoretical underpinning of the research design was grounded in the model of mother, scholar, practitioner, as depicted by the figure. And that's a reciprocal perspective through which each role reflexes with the other.
So this project was grounded in the understanding that parents of autistic children in rural areas often face limited access to support and have fewer services, specialists, and peer supports nearby, which can make parenting a more stressful and isolating experience. This project also explored using strength-based frameworks, including appreciative inquiry and the ideas framework from Claire O'Neill's book, The Strength-Based Guide to Supporting Autistic Children. These approaches provided a roadmap for parents to use tools and positive psychology strategies to support and advocate for their children, focusing on strengths like creativity, persistence, or humor rather than deficits. Sessions were delivered online via Zoom, and this approach helped to overcome geographic barriers with our participants and allowed parents to participate from the comfort of their own home. I served as both a facilitator and a researcher, and also as a parent of an autistic child. This shared lived experience helped to bridge trust, understanding, and a genuine sense of connection with participants. Critical reflection played a key role in this project, and given my intersecting roles, ongoing reflection and uncovering any potential biases was important. So continuing asking myself questions like, am I being fair and supportive to my participants? This project ensured sessions were more equitable, compassionate, and responsive to the needs of participants. The overarching aim was to improve future supports, and findings were intended to inform practical, scalable strategies for supporting rural families raising autistic children, grounded in community-informed practices. In terms of our findings, so parents reported becoming more patient and better listeners, using new communication strategies that let their children take the lead in interactions. Parents gained confidence in advocating for their children while highlighting their strengths through systemic barriers. Those systemic barriers in schools and services remained a challenge. Parents shifted towards a growth-based mindset, focusing on what their children can do, celebrating small successes, leading to lasting changes in perspective. And Zoom sessions increased access and fostered a sense of community. While some parents missed the in-person familiarity, the overall format was convenient and supportive overall. And then overall, the program helped parents feel less isolated, more capable, and more hopeful, demonstrating that online strength-focused learning can make a real difference for rural families.
The mixed method analysis was based on data collected through pre, post, and 3-month retention surveys. The quantitative component included 4 metrics measuring family stress, efficacy, and empowerment, while the qualitative questions were developed using an appreciative lens.
In terms of future directions, we are developing a new learning series aimed at reaching a more diverse set of parents and caregivers, including participants from varied socioeconomic, cultural, and family backgrounds. Additionally, we're committed to engaging more educators in this work and also expanding our work to include healthcare providers and maybe even policymakers, maybe even local MLAs and other decision makers, which may help identify and address systemic barriers faced by families of neurodiverse children. The ultimate aim of this work was all about building stronger families, breaking down barriers, and creating a future where every child's strengths shine. So thank you for your attention today, and we look forward to your questions and comments.
Excellent. Thank you very much, Karen and Shendah. I love that this is a collaborative effort, practitioners, academics, and this is quite novel and very well organized and thought about practical and policy implications. So congratulations to this work. Next in line, we have Kylie Pick.
Kylie, yep.
Kylie,
Hey.
sorry, I apologize. Kylie.
Let me just make sure. Ooh, can you guys see?
Yes.
Beautiful. Great. Hey, good afternoon, everyone. Thanks for the opportunity to present today. My name's Kylie. I'm a 4th-year medical student at the UBC Northern Medical Program. I'm excited to share findings from a project that I worked with my supervisor, Dr. Evan Jost, who is a surgical oncologist in Prince George and has now moved to Kamloops. And we focused on exploring the factors associated with the use of sentinel lymph node biopsy for primary cutaneous melanoma in northern BC. So as many of you may know, in many cancers, the lymph nodes are the first site of metastases, and the first node affected is called the sentinel lymph node. So assessing whether the nodal basin contains cancer cells provides crucial information about disease stage and prognosis. The sentinel lymph node biopsy is therefore a key step excuse me, in melanoma management and helps guide further decisions around treatment. However, at UHNBC, we noticed that there seems to be a discrepancy in that not all patients who meet guideline-based indications for sentinel lymph node biopsy actually undergo the procedure. So this led us to ask the question, what factors are associated with whether a patient receives a sentinel lymph node biopsy? To explore this, we conducted a retrospective chart review of all adult patients diagnosed with primary cutaneous melanoma between 2018 and 2022, so after the new AJCC cancer guidelines came out. We excluded patients with melanoma in situ and those with known METs at diagnoses. And then we analyzed 4 key pathological factors known to increase the risk of nodal METs, including Breslow depth, ulceration, mitotic rate, and microsatellites. In total, we identified 159 patients. Of these, only 54% underwent a sentinel lymph node biopsy. And when we looked at the factors associated with biopsy completion, we found that ulceration was associated with the likelihood of having the procedure completed. And then among the patients who underwent the procedure, Breslow depth and ulceration were both significantly associated with positive sentinel lymph node biopsy results, meaning that they were predictors of nodal metastases. So in summary, our findings suggest that not all eligible melanoma patients in northern BC are receiving sentinel lymph node biopsies despite meeting criteria. Understanding why this discrepancy exists, whether it's due to patient preference, provider decision-making, or access to surgical services, is an important next step for our project. Ultimately, by identifying and addressing these factors, we can improve the consistency and quality of melanoma care across the region and ensure that patients receive guideline-aligned management. Thank you for your time.
Thank you very much for this presentation and for being interested in this type of very special topics. Yeah, all the best in your education. All right, so next in line it's Robin Roots. It takes a northern village.
Thank you, Marcelo. Hopefully you can see my screen okay.
Oh, good.
Yeah, great. Thank you. So, Hadi Robin Sahutni. So my name is Robin. My doing self is as a physio and associate professor of teaching in the Department of Physical Therapy and regional clinical lead for the MPT North based at UNBC. And I'd like to acknowledge with gratitude my dear colleagues, Dr. David Anakwe, who's also kind of on the call today, and Dr. Teru Manyanga, who is, I think, moderating another session, who not only helped pull this poster together, but are here day in and day out to help keep the MPT North program sailing and our students, being successful. So our little study grew out of one of those sort of water cooler hallway conversations when we were supporting each other and reflecting on the challenges and also the gratitude of the work we do in an effort to address the scarcity of and limited access to physiotherapy services in northern BC. Like most health professions, there's a shortage of PTs nationally, provincially, but maldistribution is one of the critical things where here in the north, certainly in the northeast, we have about 1/3 of the provincial average with about 30 PTs per 100,000, and then the northwest and the central interior being slightly better, but still well below the provincial average. So as many of you know, one strategy to address maldistribution is really around facilitating students to train closer to home with the intent that they'll end up practicing there in the future. And so prior to the launch of the fully distributed program in 2020, we ran a clinical education program where students did their clinical education in rural and northern communities across the province. And the practice outcomes from that program certainly indicated that it was statistically significant that the northern and rural graduates ended up in northern and rural practice. We only had 3 cohorts of the MPT North program, so it's way too early to tell, but we think we might be kind of trending in the right direction. However, as many of you know, running a health profession program is incredibly resource intensive. And so it really we felt that there was a need to sort of pause and really think about where we can put our efforts and how do we sustain this in the long run. So doing kind of that resource intensive program requires a lot of coordination with multiple institutions, demands a lot of our clinical community, and yet there's the context. And I think as Dr. Brianna Wood talked about in the lunch hour session about place-based and how important that piece is for all of us as educators, but also as clinicians. We wanted to take a step back and sort of reflect on the ecosystem. So we took on ecosystem and relational mapping approach to consider what existing and potential tensions are and gain some perspective around those tensions and those strengths to really identify what do we needed to focus on to ensure sustainability. So as I noted, some of the tensions are around the limited supply of clinicians that support classroom and clinical education and teaching amidst the shortage and the high vacancy rate. So that's certainly leading to kind of burnout and reduced ability for our clinicians to teach because of clinical care demands. But it also really highlighted for us, and a revelation for us, is that a large number of our teaching capacity is made up of Northern and rural cohort graduates. So this really illustrated that interdependence between academic programs and regional health systems, and addressing recruitment and retention and service delivery. Another critical piece that we highlighted was really the community support that our students receive. So both in terms financially from scholarships and bursaries, but also the Northern Medical Programs Trust, which really supports clinical learning, our patient partners that are invaluable teachers for our students. And really also, I think the piece around the tensions associated with having multiple institutions that provide support and provide coordination, and yet how do we kind of balance that in the larger microcosm of an ecosystem. So really, in conclusion, we found that it takes a village, that our success, the success of our students and learners, to the success of recruitment and retention for the health system really depends upon the trust that we've built, and those place-anchored relationships that are across the ecosystem. And like a village and the residents of a village, it's really that mutual dependency that is so important. So our collective task is not to get lost in the weeds, but to collaboratively strengthen the resilience of our work for continued success.
Excellent. Thank you, Robin, for this great poster, and to really take a holistic or ecosystem approach to understand this problem, and take it a very collaborative approach to understand it, as well as to move on with the next steps. Yeah, all the best. Next in line, we have a couple of presenters, teamwork from Heather Gonmo and Nicole Beer.
Give me 1 second. I just need to click all the buttons, and my connection is kind of poor because of our storms. Just bear with me.
It's fine. Yeah.
There we go.
And
Awesome. So, can you hear me okay?
Perfect now. Yeah.
Yeah. Okay. Okay, great. Welcome to our rapid fire presentation on the third-party billing optimization project. I'm Heather, and Nicole is my colleague in this work. We're both managers in Northern Health, and we respectfully acknowledge the traditional, ancestral, and unceded territory of the Lheidli T'enneh, upon whose lands we live, work, and learn. I'm going to hand over to Nicole.
So nurse practitioners provide a critical role in delivering care across the North. However, a gap was identified in the level of support our NPs receive and the ability to generate revenue for services that are not covered through MSP. In 2024, to kind of close that gap, the nurse practitioner leadership team expanded by appointing critical roles to support projects, initiatives, and collaborative access across portfolios. The project team that Heather and I sit on was created in the winter of 2024 to identify and close the gaps to improve the process for third-party billings. The NP operational team, in collaboration with medical staff compensation, engaged with sites to determine current processes, developed detailed process maps for Northern Health owned and operated sites, created financial processes to ensure nurse practitioner third-party revenues were being retained in the nurse practitioner portfolios, provided one-on-one training sessions to the various sites, and developed and distributed instructional documentation for all of this work. So the project resulted in a standardization of third-party processes, improved clarity and confidence around roles and responsibilities at the sites, and on average started generating about $5,800 a month in revenue that was either not recognized in the MP portfolio and net new revenue. So both of our portfolios will continue to monitor revenue generation to help identify when a refresh on training is needed, as well as building in training onto our onboarding processes for new staff members. And then the next phase of our project is to actually look at the third-party billing process for non-Northern Health owned sites where we have nurse practitioners contracted to work in those settings.
And then just in closing, I think the real key piece to this that Nicole touched on is that, working together in organizations, we sort of sometimes work in silos. And so it can be really challenging if two portfolios aren't coming together to do the work, and really beautiful when two portfolios come together to make sure that things function well. So I just think it's really key of the collaboration work that's come together through my portfolio and Nicole's portfolio. And we included Nicole touched on several of these points, but we included sort of our key project highlights in this last slide for everyone to see. Thank you for having us. We really appreciate it.
Thank you, Heather. Thank you, Nicole. I think we have some time. Let me ask you about this special component of collaborations. How do you make it happen? In what ways was maybe communication, trust, etc. Particularly some with this idea about revenue generating and maybe potential sort of ideas or myths about universal healthcare access, etc. So I don't know if you can speak a little bit about that, how to work collaboratively, particularly in new topics or new ways of thinking what the NPs are doing.
I think Nicole and I had a bit of a benefit because we knew each other from before. So we sort of had an existing relationship when I moved into the NP portfolio in the fall of 2024. I would say that the biggest piece, or one of the biggest pieces, is the time we spent together. So when we struck our project team, and this directive came from our executive director that she wanted these two portfolios to focus on this work, we met in person every 2 weeks for months to accomplish a lot of this. There were many members of the team, so kudos to all of them. I actually think somebody else is in the room right now. Rebecca's here as well. So we spent a lot of time together in person. We actually still meet in person when we're able. We have the meeting still every 2 weeks, even though you could consider the project finalized. But I think it's that in-person time, building trust, sharing of information, document transparency. What was happening in Nicole's portfolio might not have been happening in ours, and now we're all working together collectively to do that work.
Excellent. Good to hear. All right. So there's just that human connection that allows to have more clear communications and expectations, etc. Okay. Interesting learnings, particularly in the era of AI or tech, that sometimes people just tend to jump into those tools one-on-one, and sometimes in-person communication still works, and that's great to hear. Perfect. So we have our last participant for this poster session, Ginat Candola, and apologize if I'm not pronouncing it well.
No, that was perfect, actually. Okay, good afternoon. My name is Ginat Candola, and today I'll be presenting what does wellness mean for rural physicians on behalf of Dr. Lisa Kyle, Principal Investigator and Associate Professor at the University of Northern British Columbia. Prior to beginning, I would like to acknowledge that I'm presenting from the unceded traditional territories of the Coast Salish peoples, including the Katzie, Kwantlen, and Semiahmoo First Nations. Okay, sorry. One sec. Sorry, can you see my slides now? Okay, perfect. Okay, thank you. Sorry. So I'll start again. Good afternoon. My name is Ginat Candola, and today I will be presenting what does wellness mean for rural physicians on behalf of Dr. Lisa Kyle, Principal Investigator and Associate Professor at the University of Northern British Columbia. Prior to beginning, I would like to acknowledge that I am presenting from the unceded traditional territories of the Coast Salish peoples, including the Katzie, Kwantlen, and Semiahmoo First Nations. According to a 2021 National Physician Health Survey commissioned by the Canadian Medical Association, more than 1 in 2 physicians and residents reported high levels of burnout and moral distress. Moral distress, if not appropriately addressed, can lead to moral injury and cause intense mental health challenges. While efforts have been made to address this through providing wellness resources by a number of organizations, including the Canadian Medical Association and Doctors of BC, research has indicated that these may not be accessed by rural physicians due to a variety of reasons, including but not limited to lack of anonymity, increased workload, and lack of time. Therefore, this project aims to address this through developing a comprehensive understanding of physician wellness and identifying practical solutions that can be implemented to support providers. Physicians working in rural or remote communities will be invited to participate. While there is no universal definition of rural or remote, we will use the definition proposed by the BC Ministry of Health to guide our approach. To recruit participants, we will share a summary of this research with our partners and key groups, such as the Rural and Remote Divisions of Family Practice, Rural Coordination Centre of British Columbia, and Society of Rural Physicians of Canada. We will also ask participants to share information with others that may be interested or have valuable perspectives. To promote inclusion, we will provide participants with an honorarium of $250. Recruitment of study participants is not without challenges exacerbated by high workload demands. To mitigate this, our team will provide flexible avenues of participation, including both in-person and virtual options via Zoom and telephone. We will leverage the team networks of Best Banner, and Condola to identify potential participants. Participants will be asked to complete a brief demographic survey, including sex, gender, and ethnicity. Interviews will be undertaken by Condola and Kyle and be digitally recorded, transcribed, and coded using NVivo 12, with each interview lasting approximately 1 hour. We will provide training and mentorship opportunities to our trainees and provide opportunities to gain experience in qualitative data analysis and reporting. Lastly, as this work has not begun yet, we are seeking feedback and suggestions from this space to adapt and improve the beginning stages of this work. I've also shared Dr. Kyle's email at the bottom of the slide if anyone would like to get in contact with her directly.
Thank you very much, Gina, for this poster presentation. So what are the timelines again about this project?
We've applied for funding, but I believe we're just waiting to hear back.
Perfect. And how many physicians are you expected to recruit?
10 to 15.
10 to 15. Okay.
Mm-hmm.
Interesting. All right. Is there any other questions from the audience that you'd like to ask Jeanette?
Just wondering, Jeanette, thank you for the interesting presentation. Is there interest in expanding the further scope of this work beyond rural physicians like other healthcare professionals, or is there any reason why you're just keeping it very focused?
I would, so Dr. Kyle is the principal investigator, so I would maybe check with her, but I think initially we're going to stick with rural settings.
Okay. Now it's our time for either this presentation or prior presentation. Some of you, the presenters, are still here in the room. That we can pose the questions that perhaps we didn't have, or we just thought about it maybe later on. Mm-hmm. And if not, maybe we can just invite the audience to maybe perhaps take a break. Our next round of sessions will start at 2:05. So basically, you have a little bit of time to experience wellness, since was the topic of our last presenter, and then have everyone back maybe at 2:00 to start a new session and 2:05. Thank you very much for all the presenters, inspiring projects, QI, research, collaborations. Has been great to get to know a little bit about these projects. So all the best if they're still in progress, and we look forward to have you again here back in 2027 with completed results in some of your cases, or additional scaling and or applications of your project. So, all right, thank you very much for being here in this session, and we'll see you maybe at 2:05. Have a good afternoon.